Nice to see so many faces. Right, so I know why you guys are all here. I want to learn how to do clear. Agreed. Yeah, we're not covering that this week because we're doing non-shockable rhythms. So that will cover next week. But the sad truth of it is, unfortunately, most of us, unless you're a very diligent student, you learn most of your resuscitation from TV shows, and you didn't really learn it from medical school, all right? So we all have this thing about, you know, the guy comes in magically, he's already got 4 drips on. The doctor already knows what's happening. He's like, give me 20 cc's of adrenaline and 2 cc's of morphine and clear, and they damage the machine, and then they go, they don't even say what voltage they're using, nothing. Nobody lets go of the bed, nothing. Even if they say clear, one of the extras is still holding the bed and pushing, all right? So today we're gonna start learning about how you actually do resuscitation, all right? So when we're talking about resuscitation, what we are talking about, a patient who is now dead, technically speaking, all right? We're talking about somebody who now has no heart activity or no cardiac activity and no respiratory activity. How do you bring them back? Now, just some statistics. Should a patient experience cardiac arrest, be it a shockable or non-shockable rhythm, even in the best of centers? So I'm talking about what you might call it, Toronto, you're talking about Harvard, you're talking about all these big hospitals in Seattle, wherever they do all this research and training, even they only have a 1 to 2% success rate for non-shockable rhythms. And for shockable rhythms, it goes up to about 5 or 6%. So to increase the chances of success for these patients, you'll find that there's something called EADs. If you visit America, UK, Australia, you'll find that every 50 meters, there's an AED, automatic external defibrillator. That's actually something that you just need to know how to put the pads, and then the machine does everything. It tells you whether you should shock, not shock, things like that, because the success rates are so low and getting the patient to hospital, waiting for the paramedics, all right? And next week, I'll show you some of that stuff as well, all right? So let's talk about basics of resuscitation and non-shockable rhythms, okay? All right, so let's start with the first, chest compressions, all right? Everybody should know this. It shouldn't be something difficult, but it is something that you need to practice, all right? Okay. So compressions, how many of you have done compressions? All of you should have done, especially if you've rotated with us. Sorry, there's just somebody talking in my ear over here. Oh, I think they muted themselves now. Sorry. Okay. All right. So we all know the basics of compression. All right. Hit the chest as hard as you can, push as far as you can, just keep on going until you touch the spinal cord, and then you do it again immediately, all right? No, you don't, all right? So how does a chest compression work? What are you doing? You are basically manually doing the work of the heart, all right? So when the heart works, it compresses, all right, what is known as systole, and it needs to relax, asystole, all right? When does the heart receive its blood, its own blood? During systole or asystole? I mean, systole or asystole? During the systolic phase or diastolic phase? Okay, diastolic phase, all right? So in fact, when the heart pumps, there's no blood going to it itself. It's only when it relaxes that blood goes into the coronary arteries, okay? So in other words, the first thing is if you don't give the heart enough time to relax, your compressions are not doing anything. You're sending blood to the kidneys, you're sending blood to the brain, but you're not sending blood to the heart itself, all right? So this is something I've often seen people do. They say, and they're just doing that, and the heart, and nothing is going to happen. The patient will never recover from that, okay? So chest compression is the important thing, is to keep it, what you might call it, well, center of the chest, all right? So here, where you expect the heart to be, just above the Zophisteum. Not too high, because then all you're doing is compressing the esophagus and the trachea. Not too low, because then all you're doing is pressing their stomach. They'll feel nice while they're dying, but not elsewhere. Nothing much else will happen, all right? So you've got to keep it in the center of the chest. You've got to keep your fingers locked. So everybody has different. Some people keep their fingers open, some do it closed, whatever is more comfortable for you. That's not the issue, all right? And when you push, you don't push with your elbows. All right. If you push with your elbows, what's going to happen is you've got triceps, biceps. They're actually not very strong muscles. They don't have much stamina. So you actually move with your hips. All right. So you're doing that. So you're using your back muscles and your glutes. So if you compare the size of those, they're much larger. They've got a little bit more stamina. But even with that, You get tired after about 2 minutes. All right. That's why, ladies, if you want to get married to an emergency physician. They've got stamina. All right. And an anesthetist will put you to sleep. All right. An ophthalmologist just wants to look at it. An obstetrician has seen enough of it. All right. And a psychiatrist just wants to talk about it. All right. Oh, there's a million of those. You get some weird ones, even the ENT one. I won't get into all of those. So the important thing, you are trying to get enough blood into that heart for it to restart. Now, some people did some wonderful studies where they actually measured the amount of pressure that needs to be in the coronary arteries for the heart to restart. And it's the equivalent of 15 millimeters of mercury. So how you would put a BP cuff? As soon as it hits 15. So the way that compressions work in a stepwise fashion. So with each compression, you're getting closer and closer to that 15. But as soon as you interrupt it, or you don't do it effectively, it drops back down to 0. So you're starting the steps all over again to try and get to start. So that's the thing to try and get, all right? So the most important thing, not too deep, all right? So 5 to 6 centimeters depth, 2 per second, 100 to 120 per minute, all right? And like I say, make sure you release. There must be a rebound, so that is diastole, all right? And not too fast, not too high, like I say, not too high on the chest, and not too fast, all right? Everybody here knows Staying Alive? Right. So that's the song that you sing in your head, all right? Staying alive, ha, 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 staying alive, staying alive. You all were not born when this thing was made, but it's still a popular song in the movies and that, right? So I had a copy of it, but it was terrible. So let me just tell you all about it, all right? The other song you can use is Nelly the Elephant packed a trunk and trundled back to the jungle. And it goes on and on, all right? But that's a very old song, all right? So rather use BG, Staying Alive, all right? The other one, you guys would be like, what were the lyrics? I can't remember. Okay. So airway is very simple. This we're talking about now, this patient has come in. This patient has got no response whatsoever, all right? So the first thing you've done is you've checked for the pulse and you can see there's no breathing. So as soon as that happens, remember CAB, compressions, airways, breathing, all right? So you've started the compressions now. Now somebody needs to secure the airway, all right? So exactly what it says here, place the patient on their back, open the airway with the head tilt and chin lift, all right? So you just pull, chin lift or jaw thrust, all right? So you're just basically opening the mouth. What you're actually doing is you're pulling the tongue forward. So what that does is that opens the airway, all right? Now, in our case, we're quite lucky because we put oropharyngeal airways and things like that. These are, if you're on the field as well, what you can do, all right? Suction the airway, clear out any foreign bodies, and insert an appropriate size Goodell or OP airway, all right? So that's quite simple, right? It's just to know, lift the chin, all right? Pull it forward or put a jaw thrust, all right? Now, when you guys do go for your BLS training, ACLS training, especially if they're not using mannequins, if they're using real people, try not to do the jaw thrust. It's extremely painful. And then the models start complaining and then you get marked down, right? Just a little thing from somebody who had to redo his, right? Now, the breathing, all right? So when we say breathing, we do bag mask ventilation initially, all right? And we're not talking about intubation. We're talking about, remember, this is just the first few seconds. You know, you're not standing with a tube and a laryngoscope walking around the emergency department, you know? So, but you do have access to a, a bag and a mask, all right? So the proper position, right? In the absence of neck injury, that's extremely important, all right? Tilt the forehead back and lift the chin. So you're just doing that. You're just trying to get an open airway. Now, at this point, you should already be putting in an OP airway as well, all right? Tight seal, that's the important point. So they're using something called the EC clamp, all right? So the EC, let me just put the video panel on, sorry, just so that the guys can see, all right? So what we're saying when we say EC, all right? You've got these two, or let's say you're doing it like this, all right? So you've got these two fingers that form a C, and you've got these three fingers that form an E, all right? So what we're doing is we're putting the E underneath here. So that's going to control that. And you're holding the mask down with the C. So you create, it's a bit difficult to do on me because you're normally standing behind the patient, all right? So you've got an E that's lifting, and then you've got a C that's pushing down on the mask. So that's how you can actually, keep it like that, all right? So, and the important thing is that it creates a tight seal. There's no use putting the mask on and all the air is coming out this way or coming out from the top. So you have to create a tight seal, all right? If you cannot create a tight seal, let's say it's a large person, you've got small dainty hands and you can't get that seal, then you use two hands, all right? You place two hands on And the person who's doing the compressions, when they've counted to 30, they go in back. And then they go back to doing their compressions. All right. So there's lots of ways to do it. Okay. And then to ventilate, you squeeze the bag over 1 second until the chest rises. Do not overventilate. In other words, don't try and push as much pressure inside. You may cause a pneumothorax or something like that. The important thing to remember in adults, it's 30 to 2. What that means, you're going to do 30 compressions and then give 2 breaths. Okay. So just remember, for adults, 30 compressions, 2 breaths. Okay. So when the breaths are going in, there's no compressions because you won't be able to get air into the lung. Okay. And for children, it's 15 to 2. The reason it's 15 to 2 is not because they are smaller. It's just that with kiddies, the reason why they go into cardiac arrest the majority of the time is hypoxic disease. So hypoxia leads to cardiac arrest in children. So what's happening is you're doubling the amount of oxygen that can go into their system. Once they get oxygen, they generally come out of cardiac arrest. Now, that's not always. Sometimes they have congenital heart problems, that they can suffer with primary cardiac disease as well. Okay, so this is your team. Now, this is in an ideal world, all right? Or if you work in a major trauma unit and you've got everything at your disposal. Like, let's say if you go to Albert Luthuli, for example, this is what you will see. For us, it's not really that good, but never mind. Let's try and see what you're supposed to have. So you're supposed to have one person that comes to do external cardiac massage or compressions, all right? You're supposed to have somebody who's in charge of airway and breathing. You're supposed to have somebody who's just in charge of the defibrillator. You're supposed to have the team leader who is the one who directs everything and says, right, you do this, you do that, let's get better on this. This is where we're having a problem. So in other words, he or she is the one concentrating on all the different parts and trying to put them together. Number 5, medication administration, you have somebody there. Number 6, ICU coordinator, if you think the patient needs to go to ICU. Now, let's be honest, the majority of the time in our situation, you may have 1, 2, sometimes 3 if you're lucky, all right? It's not important. Your nurses can help you quite a bit. You can even bring in the porters, students, nursing students. It doesn't make a difference. Get whoever you can to help you in whatever capacity they are comfortable, all right? So if you need somebody, for example, to, well, don't worry about stenotomy card. I've never seen one at this hospital or many other hospitals, so don't worry. But let's say you need somebody just to keep an, maybe you've intubated and you need somebody just to press the bag. You can call one of the porters. It's not a problem, you know? If you need somebody just to do compressions, you may have a junior there, somebody who's not even trained that well, but you can show them how to do it. But get as many people as possible, all right? So like I say, this is the idea. Sometimes we need to combine roles, all right? So for example, the team leader may be the one who intubates. The nurse who's handling your defibrillator will also be giving the medication. The person who's handling airway and breathing may have to first start putting up an IV, you know? So these are the things we have to look at, you know? It's just the reality of our situation. But just as long as you know, these are the components that you need, okay? Now, number 3 is the one that you actually don't need a lot of the time. All right, but ideally there should be somebody, all right? The most important thing, don't waste resources by not having definitive roles. In other words, like in our case, the bell rings for a recess, 3 people go to put up IVs, 1 person stands as a team leader, and somebody is standing over there ready with the medication, but there's nobody doing compressions and there's nobody doing the airway. It doesn't help. So immediately as soon as it comes in, somebody should point and say, go get this, go get this, go get this, go get that. Ideally, the most senior person on the floor should be the one who dictates what happens. Okay, so that's just, especially when you go for your ACLS and that type of training. All right, and the communication is meant to be what they call closed loop communication. All right, so the team leader gives a clear assignment to the team member. So for example, I tell Dr. Singh, please go and intubate the patient. The team member responds with a voice and eye contact. No problem, Dr. Mohammed. All right. So I listen for that and make sure. All right. And then the team member reports when the task is complete and reports the result. Dr. Mohammed, I've intubated now and I'm back. That's a simple thing. All right. So the reason for that is so that you can keep an eye on different things. All right. So I say, okay, you know what, one of you go and do compressions, for example. So you turn around and I'm doing my compressions. Now you don't have to keep on saying, okay, I'm still doing compression, I'm still doing compression. But you can, for example, tell me when there's a pulse. Now I've got a pulse, all right? So this is the way that you do something, all right? And if you are issued a command that you don't know how to do, so for example, I tell you intubate. but you never intubated before. Then you have to say, Dr. Mohammed, I'm not comfortable with intubation. Then we say, okay, go and do the compressions. Who knows how to intubate? Or I'm coming to you. So that's how it must work. All right. It mustn't be everybody just standing there hoping that everything's going to go well. You need to have a definitive plan and concentrate on your role. So if you've been given the role of doing compressions, you don't worry about the medications that are going in. If you've been given the job of getting the medications, you don't worry about the intubation. Do you get what I mean? Concentrate on your role and know what's going to happen. Okay. Right. Now let's get into the fun part. I just wanted to get those basics out of the way. So this morning you woke up, you picked up your iPhone 13 Pro, cost 35,000 Rand, I think, or your Samsung 22 Ultra, whatever they call those things now, right? And you switch it on and it's glitching. So the screen is going on and off. Your apps are not opening. They're just crashing on their own. So you phone the help center. What's the first thing they tell you to do? Reboot it, isn't it? Yes. Switch it on and off again. Agreed? So that's what they normally tell you. Switch it on and off again. You can pull up a chair. Come sit on this one. All right. So that's what they normally tell you. So what they're hoping is that you can reboot it. All right. So that's a defibrillator. All right. In essence. So what happens if you wake up in the morning and the same iPhone 13, Samsung 27, whatever it is, doesn't even want to turn on? Now you phone the help center and they say, switch it on and off again. What are you going to tell them? I can't even get it on. How am I supposed to switch it on and off again? That's the essence of non-shockable rhythms. In other words, there is nothing going on. There's nothing happening. So the first thing I need to do is switch it on. Understand? So when we get a non-shockable rhythm, our only objective is to get the heart started again. We're not worried about getting it into a perfect rhythm and everything must be working properly. Our first objective is switch it on. Okay. So there's two non-shockable rhythms. Cardiac asystole, which is very simple. It's just a line. All right. So if you see a line, this patient is in asystole. And the second one is pulseless electrical activity. So what that means is you cannot feel a pulse, but on the ECG, the 3-lead ECG, there is something. It may not necessarily look like this. Truth be told, it can look like anything. All right. It can look like what you call it. There can be huge gaps in between. They can be narrow. They can be wide. They can be small. They can be tall. But these are the two non-shockable rhythms. Okay. So you guys remember that, right? There's two, asystole and very good. Okay, I'm going to ask you in 5 minutes when it's not in the screen. Okay, right, and we'll see. Now, these are the causes of cardiac arrest, right? These are called the H's and T's. We're not going to go through each of them, but these are on every emergency department wall. These are the things that cause cardiac arrest, all right? Hypovolemia, hypoxia, acidosis, hypokalemia, hypothermia, hypoglycemia, toxins, tamponade, tension pneumothorax, MI, pulmonary embolus, and trauma. All right. So as you are resuscitating this patient, you've got to start working through that list, either from history or clinical science, and try to figure out what is the cause. This is just by the way, all right? So in other words, once you start the resus, you start thinking about these things already. Okay, you don't have to memorize them. It is good to memorize them, but generally you'll have, even ours, we've got our H's and T's on the side. So this is the algorithm. How many of you have attempted to learn this thing? How many of you have failed? All the time, isn't it? Okay. So I was going to put you, I don't blame people for getting confused, even though it's a simple algorithm. It's not a very difficult thing. Right? The problem is it looks very complicated when you look at it. It looks very, very complicated when you look at it. So when people are trying to learn it or trying to know what to do, they just switch off. That's what I did. First time I did ACLS, I just looked at this thing for 5 minutes and I can't learn this. It's too difficult, you know. So let's simplify it and take it from there. All right. So let's look at the simplifier. So don't worry about this part for now. All right. Let's just leave that out. Your patient comes in. You check for the pulse. All right. And there's no pulse. The next thing you look at is your ECG. There is asystole or pulseless electrical activities. What's the next thing you do? Begin. You don't have any information really on the patient, right? Just trying to keep them awake. So what do you, get them back. So you start your compressions, airways, and breathing, all right? Now, you generally continue for about 2 minutes, and then you give adrenaline. All right, 1 m. You can either give it neat, or you can mix it with 9 ml of water. Right? I know it seems like I'm rushing through this, but you guys will see why just now. Right? You check for pulse and ECG after every 2 minutes. If there's nothing, in other words, there's still no pulse, the ECG still looks the same, you continue your CPR for 2 minutes. Then you check again. You continue with your CABs. You continue for 2 minutes. You give adrenaline. Then you check your pulse again after 2 minutes. All right. So what we're going to do now is that I'm just going to, let's go back to the previous slide. Let's practice this for a little while. Okay. We're going to go round and round with one another, and you're going to see how easy it is. Okay. So patient comes in. What's the first thing you check? You check for the pulse. Very good. Okay. The patient has, sorry, let me just get this a bit. So the patient has no pulse. What do you look at next? Should be on a screen. The ECG. All right. So the ECG is either going to be asystole or PA. So the patient's got that. What do you do? Compressions and wagging. How long do you do it for? 2 minutes. After 2 minutes, what do you give? Very good, 1 m. All right. And then check for pulse and ECG. All right. And you see it's still the same. What do you do? Don't stress, we'll get it. Compressions again. For how long? For how long? 2 minutes. After 2 minutes, check the pulse. All right. Check the pulse and check the ECG. All right. It still hasn't changed. What do you do? CPR for 2 minutes. All right. Now 4 minutes have passed. Now what do you give the patient? Give them adrenaline, 1 m. After 2 minutes of continued CPR, what do you check again? Right. It shows no change. What do you do? Start compressions again. For how long? For 2 minutes. The patient still has no change. What do you give them? Very good. Then you continue CPR for 2 minutes and then you check. All right, there's no change. What do you do? No. Check for the pulse. Look at the ECG. There's no change. You do compressions for 2 minutes. After now those 2 minutes again, what do you give? Very good. You check after 2, and then you do CPR for 2 minutes. And then you check for, there's no change. What do you do? Compressions for how long? 2 minutes. All right. And after 2 minutes, you check for? It's an ECG. There's still nothing. What do you give? Adrenaline. And you continue? Compressions. And then you check for? Pulse and ECG. There's no change. What do you do? Very good. You check for? After, very good. There's no change. What do you do? Compressions for how long? 2 minutes. And then, do you get what I'm trying to say? You're doing the exact same thing. Now all of you are like, it's so easy, it's nothing major, all right? So what looks like a very scary algorithm is actually very simple, all right? The only things that are a little bit different, okay? So your pulse check is every 2 minutes, all right? Your adrenaline is every 4 minutes. So that means every second pulse check. There's still nothing, give another adrenaline. Can't give adrenaline every 2 minutes, all right? So basically, no pulse. Sorry, let me minimize this. No pulse, asystole, you do your compressions for 2 minutes and you give adrenaline. You continue your, what you might call it, compressions for 2 minutes again, and you check for your pulse. Oh, sorry, maybe these two should have been around the other way. It might have made it easier. And after 2 minutes, you check for a pulse. There's still no pulse, you continue compressions for another 2 minutes. So you've completed 2 rounds of CPR, then you give adrenaline. Do you get what I'm trying to say? That's all that there is. The reason why you are giving adrenaline is that you're trying to switch the heart on. All right. Now, you don't know what's going to happen when the heart switches on. What are you going to get? But you need to switch it on first. All right. Just like your phone, you may switch it on and it says update needed. You may switch it on and all your apps are still crashing. You don't know But until you switch it on, you're never going to know what's going on. Now, of course, in the meantime, you're taking your bloods, you are running your fluids and things like that. You're getting a history. So all of that is going on, but they all happen simultaneously. It's not that you do compressions for 20 minutes, then you go and ask, so what happened to the patient? Then you decide, okay, now I'm going to take a blood test. No, all these things carry on at the same time. All right. So it's a simple circular path. Let's take it easier. Patient has no pulse, asystole, CPR for 2 minutes, continue for 2 minutes, give adrenaline, check pulse ECG, continue CPR for 2 minutes. So adrenaline goes in every 4 minutes, pulse check and ECG check every 2 minutes. Okay, and you can repeat that for 4 to 5 cycles. So that should generally give you between 16 and 20 minutes in total. Okay, so go back and learn this algorithm. Get the hang of it, because this is a very common thing that you will see. All right. And remember, it's not difficult. You are looking at what's there, doing CPR, giving adrenaline. The only thing I wanted to say was, let's say this was the first cycle. Once we see there's no pulse and no asystole, then we would give one adrenaline there immediately. All right. So I just didn't want to confuse you all at the start before you got the rhythm down. All right. So you just for that first round, you give 1 amp of adrenaline immediately, and then it follows exactly as we are doing. Okay. So it's a 4-minute cycle. All right. Everything here happens in 4 minutes. Okay. So get this into your head, because no matter what you can become a dermatologist. All right. And if a patient sitting in your rooms dies, you can't sit back and say, oh, I'm a dermatologist, I don't know how to resuscitate. They look and say, you're going to jail. I'm sorry. You're a doctor. You're supposed to know how to resuscitate. Yeah? If you're a radiologist and the patient drops on the table, you can't go running looking for help. You've got an emergency trolley. You are supposed to know what to do. All right. So just one last thing. So what happens after 20 minutes now? We don't see any response. We've only had PEA and asystole for all that time. All right. The question is now, how do we say our patient is dead? Because it's a legal thing as well to declare somebody dead. All right. So there's a few ways that we can do it. So most people know this one, the corneal reflex. All right. Where you take something soft and you brush it against the cornea, and you should get a blink. All right. If your patient's still alive. Okay. If you don't get a blink, then it means there's a good chance your patient is dead. But if you only use that, it's not the best one. What if your patient has an intracranial injury? It has paralysis of that from before. You don't know, right? So you can't only use that. Okay, so there are a few others that we use. So the second one that we can use is called the doll's eye. This one here is called the doll's eye, all right? So what happens is when your midbrain is still intact, all right? Let me just show it to you here. So when your midbrain is still intact, and you're still alive, if you were to turn the patient's head, they keep their eye fixed on one spot, just like that. All right. That's the doll's eye movement. If you get these dolls, the eyes that move, so they do. But once a patient is dead, the eyes move with the head. Okay. Then you've got the one that we all know, the pupillary reflex. All right. So the pupillary reflex, fixed dilated pupils. Simple one. All right. So now you can check all of these 3 quickly. Number 4 is caloric testing. All right. So caloric testing, what it is it's taking very cold, freezing water, actually, about 20 to 50 mils, and you instill it into the ear. All right. Now, if you instill it on the left ear, your patient should automatically either look or have nystagmus towards that side. All right, that's the reflex, and vice versa for the right side. Okay, so you get the patient having nystagmus and doing something, and if the patient has passed on, there's no reaction whatsoever. Okay, so these are the 4 common ones that you can do at the bedside normally. All right, the 5th one is cardiac ultrasound. So you put a probe on the heart, and you see there's nothing happening. The heart is just at a standstill. That is also a confirmation of death. The last one is used more in ICUs, okay, than anything else. Patient is ventilated. You're not sure if they are alive or dead, or if there's a brainstem death. What they do is they cut off their oxygen supply. Very simply, I mean, there's a specific way to go about it, but the simple thing is you switch off their oxygen intake, You wait for the carbon dioxide levels to rise. So for all of us, once our carbon dioxide levels rise past at a certain point, we reflexly take a breath. Okay, so if the patient never takes a reflex breath, they go on as well. All right. The reason I say is even if you end up doing like ICU rotations and things like that, then you'll see that. Okay. So that's an introduction to the simplest part of resuscitations, right? Which is non-shockable rhythms. Very easy. Do you guys know? Should we do one more round of this, that? Or you got it? Sure. Go home and practice it to yourself. All right. Sit with the mirror and say, right, 2 minutes, do this, 2 minutes, do that. Okay. Because it is something that you need to know. All right. Resuscitation is extremely important. The sad part with resuscitation is you don't have time to check. You can't pull out your phone. How do I resuscitate a patient with asystole? By the time the thing comes up and you find it, patient to mortuary for postmortem. You get what I'm saying? All right. So this is just a joke to finish off. All right. So any questions or anything that you want to know or anything that doesn't make sense, even the people on Zoom, if you'll have any questions or anything you want to know, anything that doesn't make sense or anything that you struggle with, the one thing I can tell you, it is the most panic-inducing thing that you will face in your life is to have a patient who has had a cardiac arrest in front of you. The worst thing that you can do is panic more. Because when we panic, all our files get muddled up in our brain, all right? And you know what to bring forward. So what happens is you heard Dr. Mohammed saying something about adenosine when a patient's got tachycardia and things like that. And this might, what if this is a tachycardia? And you give a patient in cardiac arrest adenosine and you stop their heart completely again. You haven't helped anybody, and all you've done is make the case against you stronger, all right? Or you remember Dr. Mohammed said something about amiodarone sometime, and you just give it. No. Concentrate. Think, what am I trying to do here? I'm trying to switch this phone on, this person on, all right? How am I going to do that? With adrenaline. So I need to know the algorithm for that, okay? So that is the simplest algorithm you learn in the whole of medicine. Shima? 4 to 5. Then you do your test for death. And if there's nothing, you'd stop it. All right? The only times you continue longer, children, and those who've over ingested on beta blockers, calcium channel blockers, or any sort of cardiac medication, because then it's the heart that's primarily involved, but it's due to toxins. So then you can extend to 45 minutes. All right. I've heard of people going up to 90 minutes for children and things like that, which you can do if you've got a big team and things like that. The other thing I was going to say is compressions are very tiring, extremely tiring. So it should be that we switch every 2 minutes. In all honesty, sometimes we don't have the staff to do that. So you carry on as long as you can, and then you get somebody else to help you. Okay. Right. Any other questions? Everybody's okay. Brains are tired already. Won't make it through the rest of Thursday. Let's get the sick notebook. We'll give you all off. All right. All right. But if there's no questions, I will stop it there. I'll post the video on the group a bit later, so you can go through it again. And next week, then we'll be covering shockable rhythms. So you want to get a bit more out of it, go and just have a look at it. You don't have to memorize everything, but just have a look at the algorithm, some of the theory behind it, and then I'll try and teach it to you next week. Okay. All right. Then we'll do the bad one, which is pediatric resus. Very difficult. And then we're going to test all of you to see, do you know what's going on? Because you need to know it. Okay. All right. Otherwise, we'll stop it there. Okay.